Hello bears, it's Muhammad Hamd and today I'm going to present an unusual source of infective endocarditis and a rare clinical presentation. At this lecture, we are going to discuss an infective endocarditis case caused by Enterococcus faecalis that was set at gastrointestinal tract and moved towards heart through blood vessels as a result of intestinal perforation. So, what is Enterococcus faecalis? It's a gram-positive gamma hemolytic streptococcus bacteria that grows in chains. It may cause urinary tract infections, bacteremia, bacterial meningitis, and endocarditis. Fan and others mention that 5% to 15% of E. faecalis cases are infective endocarditis, and mention that it's the third most common cause of infective endocarditis. The conventional site of infection for individuals with E. faecalis caused infective endocarditis, which primarily affect older men, is the genitourinary tract. According to population-based research, up to 25% of individuals with community-acquired E. faecalis bacteremia also have infective endocarditis. Many patients with enterococcal bacteremia also have associated infective endocarditis. Moreover, a bedside screening test with about 100 sensitivity is necessary to rule out infective endocarditis because it is considered to be a high risk for high mortality rates. To overcome infective endocarditis diagnosis limitations, Berger and others developed a tool called the de novo scoring system to determine whether to include or exclude infective endocarditis diagnosis. The de novo scoring system is the bedside screening test that has the best sensitivity to rule out infective endocarditis. The de novo scoring system measures the following: the length of symptoms lasting 7 days or more, embolization, the number of positive blood cultures 3/3 or the majority if more than 3, prior heart valve disease, unknown etiology of bacteremia, and auscultation of heart murmurs. The de novo system also helps in deciding whether to use transesophageal echo or not in patients with enterococcal bacteremia who has a high clinical suspicion of infective endocarditis. The de novo scoring system is used. In particular, transesophageal echo is necessary to look into infective endocarditis further if the patient has a score of 3 or more on the de novo checklist. Furthermore, only 1% to 3% of individuals with infective endocarditis go and develop acute coronary syndrome, making this an uncommon clinical manifestation. A 69-year-old female patient mainly complained of chest pain, shortness of breath, and diaphoresis the night before admission. She has a past medical history of hypertension, type 2 diabetes mellitus, hypersensitivity pneumonitis, right breast cancer, and obesity, and a past surgical history of gastric band placement and right lumpectomy. Cardiovascular and respiratory examination revealed nothing to worry about and everything was normal. ECG revealed an ST elevation, myocardial infarction. Cardiac workout shows elevated troponin levels more than 10,000 nanogram per deciliter. The patient's social history was relatively unrelieving, with the patient denying tobacco use and describing herself as a social drinker of alcohol. Physical examination was grossly unremarkable. The patient was immediately started on aspirin, heparin, and statin therapy, and taken to the cardiac catheterization laboratory for percutaneous coronary intervention. Cardiac catheterization was performed as a protocol for suspected acute coronary syndrome through radial artery, and as you can see that it revealed a stenotic lesion. Notice the mark near the blue arrow in the left anterior descending artery. Stent placement was done in the left anterior descending artery at the second image, while improved blood flow within the left anterior descending artery was noticed after the intervention. Hospitalization day number 1. The patient developed left upper quadrant abdominal pain. No specific interventions was taken. In the second day, the patient developed diaphoresis, shortness of breath, and fever, tachycardia, and hypertension. CBC was done and shows leukocytosis. White blood cells count was 16.5 multiplied by 10 power 3 cells per liter, and the lactate concentration was 1 millimole per liter. Also, abdominal ultrasound was done and revealed splenic infarction, high-grade stenosis of the celiac artery, and mild thickening of the splenic flexure. Also, transthoracic echo was done and revealed ejection fraction 40%, apical and mid-anterior septal wall hypokinesia, and trace pericardial effusion. According to previous investigations, the patient was determined to be diagnosed as cardiogenic shock. According to the diagnosis, the patient started immediately on milder medication, and central venous catheter was inserted to obtain central blood cultures and to start cefepime and metronidazole as prophylactic antibiotics for any potential source of infection. In the third day, blood cultures exhibited the growth of gram-positive cocci in pairs and chains, and an increased level of white blood cells. Count was 26 multiplied by 10 power 3. Vancomycin was started, and blood cultures was retaken. In the fourth day, E. faecalis was identified as the causative of acute coronary syndrome that is related to infective endocarditis. After this result, ceftriaxone 2 gram by 2 and ampicillin by 6 was started, and urine analysis and culture was obtained. On the fifth day, the patient was still stable, afebrile, and white blood cells count continued to trend downward. Urine analysis revealed leukocytes and negative nitrates, while urine culture demonstrated no growth. However, repeat blood culture showed gram-positive cocci in pairs and chains, while repeated abdominal and thoracic CT scans showed worsening bilaterally in pleural cavity and showed pericardial effusion. On the sixth day, the de novo scoring system was used to determine whether to perform transesophageal echo for potential infective endocarditis. The patient attained a score of 3 because she likely had septic embolism to her spleen and unknown origin of bacteremia and 4 positive blood cultures. The de novo clinical scoring system indicates that any patient with enterococcal bacteremia who attains a score of 3 or more should undergo transesophageal echo to investigate for potential infective endocarditis. Transesophageal echo was performed and revealed that large mobile vegetation that size was 1.5 multiplied by 1.6 centimeters with irregular borders in the mitral valve. Transesophageal echo showed mild mitral regurgitation while no mitral stenosis was noticed, and ejection fraction still 14%. So, the cardiothoracic surgery department was then consulted regarding the need of mitral valve replacement. So, as you can see, transesophageal echocardiography shows the mobile vegetation on the mitral valve. Doppler ultrasound of blood flow through the mitral valve was seen at the bottom picture, and another view of the vegetation in the mitral valve. Notice the blue arrow there. At the seventh day, blood cultures revealed again the presence of E. faecalis as the causative organism. It was susceptible to ampicillin, gentamicin, and penicillin. Brain CT scan showed a small asymptomatic focus of subarachnoid hemorrhage in the left frontal lobe, and MRI revealed multiple emboli in the left frontal lobe. Left spine MRI also was concerning for discitis and osteomyelitis at lumbar 1 and lumbar 2 vertebrae. Carotid duplex ultrasound showed more than 50% stenosis and incidentally revealed a right internal jugular vein thrombosis. Because of the patient's small focus of subarachnoid hemorrhage and high risk of bleeding, intravenous heparin was held. The result of this workup confirmed our suspicions that the patient's symptoms were likely due to a septic emboli secondary to infective endocarditis. However, the source of infection leading to the infectious endocarditis remains unknown. Gastrointestinal and general surgery departments were consulted for further investigations of this theory. Esophagogastrolaparoscopy was done and revealed gastric mucosal atrophy, and colonoscopy was done and showed a perforation of 20 centimeters from the anal verge and at the rectosigmoid junction. This perforation was closed endoscopically with suture and hemocrit. The patient developed hypoxia and tachycardia after the colonoscopy. Physical examination done and revealed diffuse abdominal tenderness, guarding and rebound tenderness with loss of pulse. Patient was immediately underwent a non-invasive positive visual ventilation and given epinephrine. The general surgery department was urgently consulted because of concern regarding perforated viscus, and the patient was taken to the operation room. Exploratory laparotomy revealed no intraperitoneal contamination or rush of air upon entry. However, air was present in the mesentery, consistent with extraperitoneal perforation of the rectum as diagnosed by general surgery. The surgery team's assessment at the time was that the perforation appeared to be chronic in nature, when the omnitio adhered to the descending colon. An endcolostomy was performed and the patient was admitted to the intensive care unit because she was not good candidate for mitral valve replacement and signed out of the service. Following surgery, the white blood cells elevated to 23 multiplied by 10 power 3 cells per liter, and she experienced a temperature spike of 39 Celsius. She started on 100 milligram hydrocortisone by 3 after receiving a stress dose. Her antibiotics was also switched to tazobactam and vancomycin. The patient's tracheal swab cultures and blood cultures showed no growth during the course of the following 3 days. Her antibiotics prescription was changed back to ceftriaxone and ampicillin as her fever did not return. She did, however, eventually experience severe kidney injury and ventilator associated pneumonia brought out by Stenotrophmonas maltophilia. The third most common cause of infective endocarditis is E. faecalis. Most identified causes of E. faecalis bacteria occur in the genitourinary tract, but the exact source is unclear. However, E. faecalis can translocate from the gastrointestinal tract and produce bacteria and infective endocarditis, since it is a natural component of the gut flora. Our case was unique for 2 distinct reasons. First, our patient potentially developed acute coronary syndrome secondary to infective endocarditis. So this is rare because acute coronary syndrome only occurs in 1% to 3% of patients with infective endocarditis. The 100% occlusion of the patient's left anterior descending artery, however, was most likely caused by a septic embolus from her mitral valve vegetation. Additionally, our patient fit the classic presentation of electrocardiographic findings, arrhythmic location, infectious source for a coronary embolus. Cariana and others found that 43.8% of patients with a coronary embolism presented with ST elevation on electrocardiography. 52% of the emboli were found in the left anterior descending artery, and the main source of the coronary emboli was infective endocarditis with a percent of 22.8%. So, the movement of E. faecalis from the gastrointestinal system into the circulation was the second unusual feature of our case. Gastrointestinal associated source of E. faecalis infections are far less prevalent than genitourinary associated ones, despite the fact that the total prevalence of these sources is unclear. Furthermore, the manner in which the patient developed E. faecalis bacteremia was unique. This patient had a silent perforation of her rectosigmoid junction that likely facilitated the translocation and caused the E. faecalis bacteremia. In conclusion, when examining E. faecalis as a possible cause of infective endocarditis, the physician should have E. faecalis bacteria or translocation from the GI tract on their list of differential diagnosis. To rule this out, a complete history, physical examination, and imaging where necessary should be performed. Furthermore, although infectious endocarditis is an unusual cause of acute coronary syndrome-like symptoms, it should still be considered a possibility if a patient exhibits these symptoms. Finally, while deciding whether to undergo transesophageal echo to look into possible infective endocarditis in patients with enterococcal bacteremia, physicians should consider the result of de novo grading system. What is our learning point from this presentation? First, both genitourinary and gastrointestinal causes of infective endocarditis can be caused by Enterococcus faecalis. Second, an uncommon clinical manifestation of infective endocarditis is acute coronary syndrome. Finally, when determining if transthoracic echo or transvaginal echo is necessary for patients with enterococcal bacteremia, clinicians should use the de novo scoring system. Thanks for your attention. If you have any question, Google and Wikipedia could possibly have your answers. And here is the references.